Good afternoon. My name is Darren Evans. I'm the Senior Scientific Advisor at USAID's NTD Division, and I've been asked to do an introduction and chair this session this afternoon on subdistrict implementation of schistosomiasis programs. I am doing something a little bit different. I have actually written down comments rather than trying to wing it. So this will be a first time. Bear with me. Due to the focal nature of schistosomiasis transmission, WHO has long suggested that implementation of programs should be done at the community or village level. The reality of doing this, however, has been impractical, and there's been a lack of tools to effectively carry out such an approach. Years ago, implementation was recommended in something called the homogeneous ecological zone, but that was never clearly defined and relied largely on environmental and statistical expertise that were not readily available to national programs. The result has been that most national programs have defaulted to using district-level prevalence for making decisions for implementation. Given the existing tools for determining where treatment was needed, that relied on using a mean prevalence across a broad area, which resulted in chronic over or under treatment of populations, not to mention a general inability to effectively measure where disease is happening in specific communities. In recent years, there has been a push towards subdistrict implementation, but this has not been a simple task. There has remained an absence of standardized, practical, cost-effective tools for accurately measuring, mapping, and monitoring disease. For many countries, moving from a district to a subdistrict implementation unit or evaluation unit means moving from dozens to hundreds or even thousands of IUs or EUs, creating logistical and managerial nightmares, as you can imagine. This is made even more complicated due to the nature of the current treatment strategies for schisto, which have varying treatment strategies depending on prevalence and various target populations depending on what you're trying to accomplish. Despite these challenges, some countries have begun operating at a subdistrict level, often developing their own tools and strategies for measuring and treating populations. In addition, new tools are under development, not only to measure disease, but also to track and manage programs. We're going to hear about some of those today, but there are still a number of unaddressed challenges. There is still the challenge of raw numbers. In large countries, implementing different strategies in hundreds, if not thousands, of implementation units can overwhelm national programs and national budgets. Determining population treatment numbers and denominators becomes increasingly complicated because they cannot often rely on census data for determining their populations. The WHO drug applications and epidemiologic reporting tools are not yet tailored to the subdistrict units. Maintaining long-term M&E strategies and control programs across so many units still needs to be determined how it's going to be done so as to be practical and cost-effective. Related to this, identifying hotspots in a timely manner becomes problematic, and this is all not to mention the conflicting and challenging goals and objectives of the global strategy for elimination as a public health problem. This afternoon, we're going to hear how some programs and partners are working through these challenges to find solutions and to improve outcomes. First, we're going to hear from our partners at FHI 360 who have developed a tracking tool and a matrix for decision making. We're then going to hear from our colleagues in Togo who have been operating at a subdistrict implementation unit for some time and have developed their own tools and strategies. This is then going to be followed by a question and answer. Sorry, this all changed this morning, so I'm going to good chance I might mess this up. A question and answer period, and I think a brief survey. We'll then jump into a 10-minute break, and we'll come back and we'll hear from some of our partners in Sierra Leone who have been using the ESPEN Schistosomiasis community tool, but having to backfill some of the gaps in information with local knowledge. And then finally, we're going to get an update on the Schistosomiasis Oversampling Strategy that is being developed to create a robust mapping tool for subdistrict implementation. This will then again be followed by question and answer period, another survey, and then I think we're done. So with that, I am going to call up our first presenter. Anna Phillips is the Learning Director and Schistosomiasis, and I'm also going to screw up all the titles. Schistosomiasis and SDH backstop for FHI 360 and the ACT-END NTD's West program.
Hi, so thank you very much, Darren. I am going to be talking about the ACT-END NTD's program and the Schisto tracker that we developed. So just a brief overview on what the ACT West project is. The ACT-END NTD's West project operates in 11 countries in West Africa. We support the control of 5 PC NTDs, of which Schisto and SDH is one of them. Specifically, so ACT West is building on previous success from the END in Africa and the ENVISION projects. It's a continuation from those 2 projects. And for Schisto activities that we support, we work in 8 countries, which I've highlighted on the map. So this is just a summary of the Schisto progress so far in these 8 ACT West supported programs. So for many of these countries, the baseline schistosomiasis mapping was done a very long time ago, and they have done multiple rounds of MDA. Some of them have done up to 18 rounds of MDA. And so in the last 2 or 3 years, we decided to help support the countries move away from this blanket district MDA approach and to start focusing on doing subdistrict MDA. So this required quite a lot of, we needed to do surveys, we needed to prioritize which areas we were going to be doing those surveys because it was going to require quite a significant investment over the 8 countries. So we created a tracker to help identify those areas that really needed prioritizing in doing the surveys. So out of the countries that are doing subdistrict MDA, 6 of them are doing subdistrict MDA. Burkina Faso, Mali, Togo, and Sierra Leone, and Benin and Ghana are starting to do subdistrict and roll that up, so it's not at a national level quite yet. So why is there this move to subdistrict MDA? As I said, many of these countries have done multiple rounds of MDA. And most recently, there's been encouragement to scale up in certain instances to community-wide MDA, but there isn't enough drugs to do that. So we're trying to prioritize areas that really need focused interventions to help combat not only that prasequantal fatigue, but the morbidity that's decreased as a result of all this treatment, and start treating at a more accurate and granular level. So here's an example just from Sierra Leone and the importance of the spatial scale of prevalence. So on the left, you can see that there's schisto prevalence. If we look at recent surveys that were conducted in 2022, so all of the endemic districts in Sierra Leone were reassessed. And if we look at just looking at the district prevalence, they have like low to moderate prevalence. But if we redid the map taking into the sub-district delineation, you can see if you're just looking on a district level, you really start missing those hotspot high prevalence areas. And similarly, it's not only about prevalence, but it's also about treatment coverage. So this actually not an Act West country, it's from Ethiopia, from the Gashiro project, but they also did a similar analysis where they looked at treatment coverage considering admin level 3, which is the subdistrict, versus admin level 2, and if they just consider looking at the district level, they would think that their coverage is okay, but then when they start looking at it at the subdistrict level, you really start seeing those subtle nuances in treatment coverage and areas, problem areas that need to be addressed and likely are aligned with those kind of hotspot areas that we start seeing. So in Act West, we developed a disease tracker for Schisto and STH. So it's an Excel spreadsheet that has site-level data, which is at the community, and then it's aggregated at the sub-district and the district level. And then we created a dashboard to visualize the data in the tracker. So the objectives of the tracker was to start uniting multiple sources of data. So when we started thinking about doing impact assessments to move to the sub-district in many of these countries, we found that so many itty-bitty studies had been done in the countries, and not just impact surveys or baseline mapping. You had large surveys like the SOS that Fiona's going to present on later, or the SCOR study. These are really good, robust scientific studies that have been done that are perhaps not always incorporated into national treatment decision-making. So we created this tracker to start feeding all data into one location so that we could really start identifying which sub-districts do and don't have data, because on an initial screening it looked like we had thousands of sub-districts that didn't have any data at all. But as soon as we started aggregating everything into one tool, we found that actually they had a lot more data than they realized. So the tracker also has robust quality control checks in it to enable quality data checking, and then it enables to monitor disease trends over time. And then it also enabled us to identify and prioritize areas that needed resurveying. So it was a good evidence base for us to be able to support countries to make this shift to subdistrict MDA. So the site-level form has lots of data in it. I couldn't really summarize it, but it collates geographical information. So the site is the community or the village-level data. So it aggregates all individual data at the village level, and it has geographical information, which sub-district the village is in and the district, and all of the prevalence data by species, and for aggregating that into any schist or any STH. And then we have a sub-district and a district tab. So the sub-district and the district, we have an R code which automates the site level at the sub-district and district level to calculate prevalence. And then off the back of this, we create a complete sub-district and a complete district list. So this has the prevalence of Schisto and STH for each sub-district or district. And it shows the baseline prevalence and then prevalence at any point in time where there have been new surveys in the country. So this enables the countries to track prevalence over time, which actually we didn't put that into the tracker initially, and then we did a data review meeting. We started off doing it in Togo was the first data review meeting, then we did it in Ghana and then Sierra Leone. And we noticed it's actually really important to look at prevalence over the time, because there were some areas that looked like they still had quite high prevalence in recent surveys. So we wanted to track how that had changed over time. And then once we create this sub-district or district list, we have recommendations on how we suggest that the country should be thinking about moving ahead in terms of treatment strategy. And that is discussed in a data review meeting held by the NTD program in country. We also have population numbers in the complete subdistrict and district lists, which help us calculate treatment needs and drug requests and what that's going to require in terms of budget if we make that subdistrict shift. So having created this subdistrict complete list, we then came up with an algorithm, start thinking about what do each subdistrict fall into. So we had the category A, B, and C, and this is what their baseline prevalence was. And then when there was an impact assessment more recently, we then shifted those subdistricts. So are they still confirmed to be in category A? If so, we didn't want to, and we brought this algorithm around because there had been the new WHO recommendations from 2022 recommending community-wide treatment above 10%. Well, there wasn't enough praziquantel, even in Act West alone, for everybody to do that. So we thought, well, we need to start thinking about how to prioritize these areas and come up with some kind of algorithm. So the idea was that if we have a category A district, so they started off above 50%, say this came off the back of a data review meeting in Sierra Leone. They did a resurvey in 2022. If that subdistrict was still category A, we looked at the treatment coverage for the last 5 years in that subdistrict. If it was consistently high, above 75%, then we said, well, that is a scenario that would really warrant and justify doing community-wide treatment. If, however, you go back to that subdistrict and it has really high prevalence, but your coverage has been 10, 20, 30% for the last 5 years, do you really want to scale up to community-wide treatment? Because there's clearly an issue there. It could be migration, it could be a problem with the drug process, whatever the problem is, but maybe scaling up to community-wide treatment might not be a solution to the problem. Similarly, for category B, the same thing, like if it was confirmed in a more recent survey, then again, if the treatment coverage is good, then that would warrant scaling up to community-wide treatment. But if the coverage has been poor, then it really warrants more investigation. So this was a roadmap of sorts that we came up with we discussed in a data review meeting with the countries. So then off the back of that, from that complete subdistrict list, we then categorize these subdistricts into this A, B, and C, whether they're confirmed to still be A, confirmed to still be B, or if not, they haven't been reassessed, then this would be flagged up to be proposed in future budgets for reassessment in the coming years. So just to touch on, I said in the complete list we had population numbers. One of the things that enables, that is useful about having the population numbers is that we're able to look at what are the treatment needs. So this is an example from Togo. We said, well, as of 2010, if we just look at the district, then we need more or less 1 million tablets. If we consider baseline data only looking at the subdistrict, it's more or less the same. Your treatment numbers are more or less the same. Once they did a reassessment of the whole country, we take the new data. If we look at the subdistrict, the treatment needs almost halved when they took into consideration the new data. However, they did it at the district level. It didn't really change much because we weren't capturing those nuances in prevalence differences between the sub-districts. The tracker also, off the back of the tracker, we created a dashboard, and the purpose of this was to visualize data in the tracker. And this is more of an advocacy piece for the NTDP managers themselves. We summarize as a whole load of graphs in the dashboard, but we summarize by district and sub-district. So this is an example where We looked at the number of districts by endemic status at baseline. Again, this is from Togo in 2009, and then how that looked in 2015. And you can see on the left, on figure 1A, this is looking at the districts. There's, a significant number of low, and there's a huge jump from high to low, from baseline to 2050. But then you can see the majority of them are low endemic districts. But then on the right, the graph, we look at subdistricts, and you can actually see that the proportion of subdistricts are actually non-endemic if you look at this, compared to the districts. So it really does become quite important moving to the subdistrict, because you're going to stop treating all those subdistricts that actually don't warrant treatment anymore, and you're focusing all the efforts on areas that do. Similarly, in the dashboard, we looked at the number of districts that needed treatment over time, and then the number of subdistricts. And I just highlighted in red, I'm not sure you can see it, but on the graph on the left, if you look at the number of districts that fell into maintaining a previous PC frequency, so you basically didn't change your strategy, the majority of the districts fell into that category, so you just continue doing exactly what you've always been doing. But if you look at the subdistricts, the graph on the right, very few relative to the other subdistricts actually continue as they had been doing before, and there's actually mixing up of a strategy compared to the districts. So finally, thanks to everyone at FHI 360, but mainly to the countries who've been filling all these trackers in, which is time-consuming, and having the data review meetings. And we did create the tracker in collaboration with ACT East, which is the Act to End Entities East Africa, which is implemented by RTI, and obviously USAID. Thank you very much.
Thank you, Anna. So next we're going to have Dr. Nasike, the NTD Program Manager from Togo, who's going to be talking about integrated program MDA for Onco, Schisto, and STH at the subdistricts. Togo has been doing this for quite a while. They were sort of pioneers in developing this strategy. So welcome.
Thank you, Darin. Good afternoon, everybody. I'm Piham Nyosike, Togo NTD Program Manager, and I will share with you our experience and the challenges of implementing subdistrict onchocerciasis, schistosomiasis, and STH MJ in Togo. So we'll begin with the history of our implementing, seeing that ONCO program started very early in 1988 and still ongoing. And we can see that PC NTD program launched in 2006, and in 2009, we already done our first baseline mapping of SCH and STH and onchocerciasis in 29 districts with 2 villages per subdistrict sampled. And in 2010, we begin our MDA, integrate MDA, with the 3 entities, SCH, STH, and OV. And after 5 years of implementing MDA, we do our first impact assessment in all baseline mapping village. So we choose the same village plane or sampled on in our baseline mapping. So after 5 years of implementing, we do our second implementing impact assessment. So for that, we are doing it step by step from 2021 to 2024. What we can also add is that since 2010, we in Togo we already experience our MDA in community. So our MDA is integrated and community based. So we are going door to door to implement this MDA for the 3 entities, and scholar-aged children are treated or based on subdistrict prevalence. Adults also are treated when we have a prevalence upper than 50%. Now we can see the results of our first national impact survey in 2015. This survey have had the objective to detect the reduction of SCH and the STH since 2009, when we have done our baseline mapping, and see how to change the regimen of treatment of MDA according to the results we will have. We use for the sampling the same village, like I already explained. In 2009, 2 villages per subdistrict, and 15 scholar-aged children sampled in every per village. And this first national impact survey in 2015 shows that we have a significant reduction of SCH and the similar reduction of STH prevalence. We have done also our second impact survey after 10 years of MDA, and this survey also have objective to update distribution of SCH and STH since 2015 survey following multiple rounds of PC. But we changed at that time the sampling strategy. The first changement is more intensive sampling. Previously, we have 2 communities per sub-district, like we said, but for this impact survey, we go to 30 to 50% of communities. We have changed also the number of children sampled. Previously, we have 15 in every school, and now for this impact survey, we have 24 children. We change also the way we have done our diagnosis. We duplicate catocats. Previously, we have single catocats, but now we have 2 catocats, and we do our urine district just after when we do our filtration, just when hemostasis is positive. We also change that the inclusion of school. We add inclusion of school wash questionnaire, and ESPEN collect also. We use ESPEN collect also for electronic data collection, and we change also our prevalence calculation, because previously we use upper bound prevalence, but now for this impact surveys we use the average. Now you can see our results. We compare that results with the baseline and the first survey, impact survey. And on this, you can see that we have we have a significant reduction of prevalence, and also intensity average of our when we have done that the second survey. Okay, what can we do when we choose to go to subdistrict MD? Because in Togo, we already, like I told you, experience this subdistrict MDA in a community, base community, door to door. And if you need to go to, you have to go to implement subdistrict MDA, first is to see that if organizational, you are ready in organizational level. It's at that, you can say that is very important to commitment at all levels, from policymakers to implementers to mid-level manager. We have also to do an investment in a CDD supervisor structure at sub-districts. It's very important because it will help you to have positive impact on MDA coverage. It's also important to see if you have a capacity to go to that implement sub-district MDA. For that, we need financial resource, because we have additional level of training and for supervision. We need also to be very organized, don't have organizational structures, and we need also to have a flexibility of our system. What is the challenge we face? The first one is the reporting system to district, or to district implementing, from training, distribution, reporting. The second one is ambiguity on how to calculate sub-district prevalence, because like I explained, first we use shows upper bound, but now for the second impact assessment we use average. So it's very important to know how to calculate your prevalence, your sub-district prevalence. What to do when there is no site level data available? It's also very difficult, because we have sometimes the new sites in the country, and which prevalence do you affect to this site? And the tracker Anna talked about now help us very much to know which data to use in this type of this problem. What diagnostics we have to use? Is it hemastis and or urine filtration? Is also very important to know which one to use. because in Togo we used to do both hemastis, but filtration on hemastis positive hemastis. Another challenge we face is also drug recurrence form, because historically the drug recurrence form have been in the district level, so it's very difficult for us to do our drug recurrence. Another challenge is also the subdistricting. When subdistrict splits, like I explained before, it makes challenges to reconduce or to update databases. We have also logistics, a problem of logistics, like we explained. Additional administrative level requires more planning from training. We use in Togo cascade training, but we can say that when you have a big country, it will be very, very, very difficult to use this type of training, cascade training, like in Togo. And we already talked about change in prevalence calculation to previously upper bound to now average. So we can conclude that it's very important to go to subdistrict, like they already show us. In Togo, we have this experience, but we face many challenges, because we have insufficient guidance for delivering subdistrict MDA. We improved also subdistrict training, supervision, and the financial management. Improved subdistrict training, supervision, and the financial management can be used to assist organizational readiness. Resources also needs to be available to make this change we already talked about. And change management must occur to all levels, from policymakers to implementers to mid-level managers to CDDs, to build strength, strategy, and consensus. This also is very important. And we need tools like tracker, or also like ESPEN. Victoria will talk about now, after. And the reporting system, reporting system need to be updated to include subdistrict treatment coverage. I want to acknowledge many people. I try to do this presentation in English. I'm not, so I want to apologize for. Thank you.
Dr. Torre, Anna, we're doing Q&A now. So you guys want to come sit up here? Do we have people online? Somebody monitoring questions from? No? Online people, I'm sorry. All right, so we've got a few minutes for, the hands are already going up. Question and answer. So they can share this one.
We
Maybe
can share that one, yeah.
People here can, sorry, just on the online people. Is there really no way to track online questions?
I can try to get on and see.
Sorry, the hand shot up in the back here. Sir, if you wouldn't mind just introducing yourself.
So, thank you so much. My name is Maurice Odiera. I'm a research scientist from the Kenya Medical Research Institute. I've got a question for Anna, and thank you so much for your presentation. Mine is just actually two. One is in some of the diseases that there's a transition from from endemic to non-endemic. I just wanted to understand how you get to that non-endemic classification. I mean, when you've not verified interruption of transmission, shouldn't you say no MDA required as opposed to non-endemic? And then, of course, the other one is about the diagnostic tools that you used in the criteria. Was that a consideration, and how did you? Was this a tier level where you are assessing the quality of the diagnostic tools? Thank you.
Hi, yeah, thanks. So we didn't say anything was non-endemic. So if they were, say, category C, and then now they are less than 1%, we do, according to our roadmap, they say they need to be validated. However, there is no protocol for validation. So they are suspended in what do you do? So currently, obviously the countries do what they want to do, and Togo is a perfect example where they have a number of subdistricts of less than 1%. We said to them, okay, you've got two choices. You can stop treatment, and then probably a validation protocol will be available in 2 years' time, and you won't have treated for 2 years, and you can do a validation survey, or you can continue treatment and then wait for a validation protocol to become available. I don't want to speak for Dr. Noske, but they decided not to stop treatment because they thought, well, what's the point? It's going to rebound back, and we're back to square one. So they just decided to continue until we have a protocol where we know what we should be doing. In terms of diagnostics, we're not doing scientific studies. We're doing implementation surveys to enable treatment decisions. So we're not doing an investigation into the sensitivity and specificity of diagnostic tools, but we're using urine filtration catechats and hemosticks, which are standard schisto survey tools. The reason that we did urine filtration on hemosticks positive samples only was purely cost saving, because we had 8 countries all wanting to roll out impact assessment surveys. We couldn't just go in depth in doing, we had to weigh up cost and practicality. Like, the hemosticks are enough to make a treatment decision. Would we validate it as being zero prevalence? No, but we haven't made that suggestion at all. We said in those zero prevalence, you definitely have to go back, but we don't have a protocol to say how we would validate that right now. Yeah.
I think I saw right before Peter, somebody, maybe it was Upendo.
Thank you. Can I sit? Okay. Yeah. Good afternoon, everyone. My name is Upendo Mwingira from the Act to End NTD East program. My question is to the Togo. I'm very excited to see that you could implement the integrated MDA. I just want to know more about how did you do that? All the tablets in one hand at one time? I could imagine 4 praziquantel, then ivermectin, then albendazole. How did you do that? And then in relation to that, what about food intake for praziquantel? As you know, that's the must. How did you do that? And I think the second question is on you have spoken about the impact you had on schistosomiasis. I'm just curious to know, and of course, the coverage of other diseases, other MDA tablets you have provided, if you have. I'm sorry, I think I was quite fast, but congratulations for you to speak English. And I think none of us, even except me, especially me, can speak even a quarter of what you do in French. That's why, so congrats.
Thank you for your questions. I'm here with Dr. Professor Dorkenou. You know her very well. So if I have a question I could answer, she will help me because it's, so for your question, we implement integrate MDA, and it's a good question because we gave all the 3 tablets together, and for until now we don't have any problem because when we compare this implementation MDA with when you use only ivermectin and albendazole, we have the same side effects. So we don't meet more side effects when we give the 3 tablets together. So it's what I can say if Dr. Professor Dorkenou or Anna will have to has to add something. And the second question is about coverage. You want to know, I don't have the data, but I can share with you. I don't have it in my mind, if I understand well your question. You want to know the coverage of that site.
Yeah, but if you did together, then the coverage is 1, I think. So there's no problem on that. But maybe, Monique, if you can explain.
Yes.
Okay, thank you. I think you have a coverage issue for some areas.
Yes, for
and
some.
you try to target using the tracker to see if it's possible for us to manage these sub-districts to better survey, follow up the distribution in this area. But for many times, I think you have a good coverage. But the question is, for all MDA, is the declaration coverage? Answer we had. That is a question for all disease, MDA disease. But if you see our data, the majority of the data we have, the coverage is good.
Okay.
Maybe back to my question. You had all the tablets in one hand for one person. So praziquantel, ivermectin, albendazole, all were given in one time?
Yes.
To one person?
To one person, yes. On one time.
If the person needs the 3 pillar, yes.
Yeah, that goes back to the 2012 guidelines. Okay, I got Peter, Joseph, this gentleman, Rachel, and then I'll work my...
Thanks, Darren. Thanks. My name's Peter Diggle. I'm at Lancaster University Emeritus as of last week. And I just wanted to make a few comments in relation to the questions that Dr. Nosike raised at the end of his talk. We often hear that schisto is focal, and unless you quantify that statement, you can neither agree nor disagree with it. But the maps in Togo that Dr. Nosike showed certainly had spatial structure to them. Now, the fundamental point about spatial structure is that if spatial structure exists over a typical scale, then it becomes more relevant to take account of that structure the smaller the EU becomes. Because basically what that means is that you are not estimating efficiently if you're only counting prevalence within EUs. Doesn't matter whether you use the mean or the upper confidence limit. It's the wrong thing to do. Okay? So it seems to me that what we could certainly be doing from everything I've heard today is continue, if the logistics demand it, to design and implement surveys at district level, but design them in such a way that they achieve required performance levels at sub-district level. And there's no incompatibility between those 2 requirements. But it does mean that you have to abandon classical statistical formulae based on the standard error of a mean, and you have to actually explicitly build in the spatial structure to the data. And I think we'll hear later from the Schisto Oversampling Study, and again in several countries, I think those of us who were involved in that study were quite surprised to see the extent to which schisto is quite discernibly spatially structured in countries, and therefore you can exploit that information to enable finer scale predictions that can achieve the required precision with smaller sample sizes.
Good point. I am going to apologize to our online colleagues. I've learned that not only can they not ask questions, but they can only see that wall. So just, we're still here. I don't know, Dr. Nasuke, Anna, if you stand in front of the computer, I think they can see you there.
Okay, thank you very much. My name is Dr. Joseph Kojela-Biopare from the Ghana Neglected Tropical Diseases Program. So thank you very much for the presentations. And I just wanted to find out, in Togo, okay, when you started your assessment, the initial one, okay, and you also followed it up with the second one, you changed the method. No. Okay, fine.
Okay, no.
But second and third, yes.
Third we change, yes.
So if you change the method and later you compared the results, what do you make out of it? Because you changed the method, so it becomes difficult to compare. Anyway, then the other thing is Ghana is about moving to the sub-district implementation. As at now, we have 31 districts that we have sub-district data. But with the problems you enumerated, in fact, I'm scared. So many challenges. You see? And even when you have to request for medication, it's at a district level. Now we have to tailor it to the sub-district and even to the community level.
Yes.
So if you have some time and you could go back to the challenges and address how you have been able to solve some of them, fine. If you don't have the time, maybe later we can talk one-on-one.
Yes, yes.
Okay?
Talk to one-on-one, no problem. To answer directly? Okay,
Yes,
thanks. We have changed our strategy from first impact assessment to second impact assessment from 2015 to 2021. But no, I will let Dr. Monique, because she is, I'm here, but she knows very well how she has done this.
Okay, thank you, Dr. Yosike. I think that because after the first impact assessment, you see the reduction of the prevalence. And I think it's and WHO moved to elimination step. And that's why we decide to have a better approach, because for the first and second assessment, you select 2 villages per sub-district. But in 2021, you use the proportional design to detect the population will be surveyed. That's why you increase the number of districts, the number of villages surveyed according to the size of the sub-district. The second modification or change is also age. For the first and second impact survey is only the school-age children age 6 to 9. But you know that the older children are more infected by the small one. And we decide to go to extend the range of the children, including in the survey. I think the objective is to really approach the target, the new target of WHO. That's why we modify now you decide to use this methodology for the upcoming years or upcoming survey, because you need to target in the area and to reduce under 1% the prevalence of infection, heavy infection in the country.
I'll point out that
Yes.
Dr. Opara is the program manager in Ghana, and they're doing a similar.
Yes,
Exercise.
and for the second part of his question, or after?
Go ahead. But
Yes, but...
we're running out of time, so.
Okay, so we'll talk about after. No problem. We can talk face-to-face after. Okay.
Hey, hi. So thank you very much for your presentation. I thought were illuminating. My name is Giulio De Leo. I'm Italian and currently based at Stanford University. I seen a recurrent question here: what do we do when there is no prevalence data available? Right? I mean, that's at the subdistrict level. But I do agree fully with you that when I saw this map, I saw a structure, and also I see a mine of data, a very rich data sets that might provide opportunity to run some of the statistical model to look for environmental, climatic, and socioeconomic determinants of those hotspot of persistence in a way that then, even in the place where you don't know, you can do some test and check whether you can, do very fine-scale precision mapping and identify that. And we have done a little bit of work in that direction. I'll be happy to continue the conversation, but I think it's the idea of having a data tracker is fantastic, is create a database that allow them to investigate all those other hypotheses there. So thank you and congratulations.
Okay, thank you. Thank you.
I think that's an interesting. Peter's also working on models for STH, and I think they're very useful tools, but they're not immediately transferable to national programs. They require a little extra thing, and I think I just heard you guys volunteer for that. Rachel, I think. Rachel and Amadou, David.
Thank you. Rachel Pullen from the London School of Hygiene and Tropical Medicine. I've just got a quick question for Anna. I think seeing existing data collated like that so that we've got data-driven decision-making is great. It's really good. It's very similar to the ESPEN workbooks, and I just wanted to ask whether there'd been, because it's a huge effort making that kind of data set and bringing everything together, and how similar the two workbooks have ended up looking, and like whether there's been a comparison between the two, and whether they've led to conflicts in recommendations. And also just a quick question on when you make a recommendation for a given sub-IU, how much data are required? Is it one site, or do you have like a number of sites required before you can assign a classification? Yeah. Thanks.
Thanks, Rachel. I don't want to gazump Victoria's presentation, because she's going to present how Sierra Leone used the ESPEN Schisto community tool and the tracker, and how useful they were. There are some differences. I would say that the tracker has maybe more robust QC checks in it, but the community tool has been a very useful basis from which we could start the tracker process. It wasn't, they really do complement one another, but she will go into more detail about that. In terms of the sites, so that's one of the things that we put in the complete subdistrict list, is how many sites did you sample? And when Darren and I went to Sierra Leone for the deep dive, we do like Schisto data review. In some of the chiefdoms, which only had one site, we were like, not sure you can make a decision based on this. So maybe in this sub-district, you might want to go back next year and just visit, 2 more sites. So Sierra Leone came up with a process in which they need to bulk out the data for that. And I did want to touch on Peter's comment that you can survey the districts. So just to be clear, when we did our impact assessments, we actually did our power calculations at the district level. So we said, we want to roughly do 30 to 50% of villages per district, which worked out to be 15 villages per district that we sampled when we did all the impact assessments. But we made sure that where possible, every sub-district within the district had a site within it, so that we were able to have some kind of information on that sub-district. Now, it turned out that that was a useful strategy for some countries like Togo, which have really small sub-districts. It actually turned out being a bit of a quagmire for Senegal, that have huge sub-districts, and 15 villages per district did not even touch half the sub-districts. So we do, it really does need to be tailored. We had to come up with a figure in terms of when we were putting our budgets together at the beginning of the year, but we hadn't delved into getting a sub-district list from each country and the village lists until it had been approved. So, we have realized that in some countries we need to go back and do some more in order to make decent decision making. But, like I say, we're not a scientific study, so we do have to balance it with cost and saying, okay, can we practically make a decision without, that it's relatively robust, but it's not a precise science survey. And in terms of the geospatial risk maps, we have a geospatial team in FHI, and we created a geospatial risk map of Togo, Sierra Leone, Ghana. And so we have done that, and then we overlaid it with the shape files from the sub-district and the districts. But it still doesn't help us with those zero prevalence areas. Yes, they're showing up zero prevalence on the maps, but the maps are also created with the data that we're collecting in the survey. So, that will have an influence on that. So we're still a little bit stuck on the zero prevalence.
All right. You had your turn.
Thank you to the presenters. So I have a question with regard to the baseline prevalence, because you had baseline prevalence for all sub-districts. So I don't think it's appropriate to use the aggregated district prevalence for all the sub-districts, because if there is no site prevalence for the sub-district, it's maybe better to leave it as unknown until you make a survey to identify the prevalence. Because for some, I've seen the change from 36% prevalence to 0. And as commented by Maurice, I think some of the sub-districts may not be endemic for schistosomiasis. It's possible that the prevalence is 0 for these places. Yeah. So it's not a change due to the MDA. They are not endemic since the beginning. And also my second comment is with regard to continuing the treatment when the prevalence is 0. It's not ethical, I think. What you need to do, if it is an aggregated prevalence, you need now to refine, because a sub-district is not big. It's a health facility catchment area. You have maybe in the sub-district 4 to 5 villages, not more. So go and refine and stop your treatment instead of continuing giving, I think, praziquantel to these people that might not need the treatment. And then my last comment is with regard to the co-implementation. I think this is something which is recommended by WHO since the beginning of the NTD program, because WHO recommends to do an overlap of disease mapping and to do co-implementation. WHO is not recommending the co-administration of all the medicines, but a sequential distribution of the package of medicine in the district, starting by OncoLF with albendazole, ivermectin, followed by praziquantel, and then you end with Zithromax for trachoma, if all are endemic in the same area. And this is the reason why WHO has developed the JAP to help countries doing the reporting at the same time, and also the request of medicine at the same time, so that they can do the delivery of this package at the same time, not all together, but I will recommend you to publish this study, because we don't have safety information, enough safety information on all this medicine given together.
Yes.
Thank you.
Okay, I think there's a lot of information there. How long is the survey?
We can do it after the woods as well at the end, the other side.
Okay, there's people pointing at their wrists in the back. So.
Okay, we can do the break and then we can do it at the end.
All right,
then
do you
you've
want
got
to
one-
address
you can do
one more question?
Yeah.
All right, I think Amadou, we had, well,
yeah.
we can talk about that afterwards.
Yeah,
Okay.
there's one thing I want to address, but yeah.
Dave or David? Dave or David?
Okay. Mine will be shortish, but hopefully a shortish answer. My name's Dave Meltman. I'm from Monterey. We've done quite a lot of work with ESPEN. I'm very familiar with the JAP files and the challenges with the volume of data that exists in those spreadsheets. You've got a whole nother level, a whole load more data within this sub-district level. What was it like trying to manage all of that within a spreadsheet? Version control, ownership, data quality, and if you had to do this exercise again, would you continue with the spreadsheet you've got, or would you look to use something else? Thank you.
Yeah, it's a good question. Would I do it again? Yes, because I feel like it's just been invaluable with our decision making in terms of budgets and making practical decisions. Togo was actually our initial country that we trialed it with, and so that was quite an easy country because they had like a wealth of data. It's quite small. They didn't have that many sub-districts. Not Ghana. They had thousands of sub-districts, and it was like opened up Pandora's box of, wow, this is a big spreadsheet. Because, you know, when you've got 150 sub-districts, you can manage that. When you've got 1,000 sub-districts, wow, that's a beast. And managing that. So I would say that we have invested a lot of LOE in creating the trackers and populating them, but we knew it was just an initial uplift. Like, we just had to do it one time, and then that was it. We could hand it to the country and say, right, here is your track, and now you can maintain it, and the majority of the legwork has been done. So now all they have to do is just add new data as it comes in, as new surveys are done, or if there's redistricting. So I would say that now it's, I'm glad we did it, because it just has been invaluable now with all the treatment decision making. But it was a lot of work for the last 2 years. But I feel like we've done the majority of the work now.
Just 1 minute to add something. Togo is the singular example because, like I show you, we already in the begin with sub-district level, community door-to-door. And also, we don't use the recommendation. Our recommendation to treat are different from what WHO said before, to be, for us, more efficient. So when we decide to change, we have many challenges, but we can talk about after, because it's not very easy to explain all this. Thank you.
Okay. I would also add that Act to End is working with COR-NTD and developing not just an Excel spreadsheet, but an integrated data system.
Oh, yeah.
Hopefully that'll.
Yes.
David, is yours a quick
Make it very quick.
Okay, last one.
Thanks, Darren. David Rollinson from GSA. A quick question. Great presentations. Thanks very much. I'm just now wondering about adult treatments and assessing the situation in adults, given the WHO guidelines of treating the whole communities over 2 years old in certain settings. Is anybody gathering any information on prevalence in adults?
Not prevalence in adults. Not in ACT, in ACT. Yeah, yeah.
Under the Schistosomiasis Oversampling Study, or SOS, in Togo and Ghana, Cote d'Ivoire and Mali, we collected data in a subset of adults, prevalence and intensity. I'm not presenting on that today, though. That's a future COR.
All right, we got it. Real quick. We're 10 minutes over.
Because the prevalence of schistosomiasis in adults differ from the intensity of the contacts. One. The second point is the duration of the water plan. So it cannot be something which is uniform everywhere. Therefore, the treatment for adults, people need to think about the type of transmission before starting MDA for adults. Some areas where you don't have a lot of contacts of adults with the water plan, you can assume that there have been children in the place, they have been infected, maybe 3 yearly rounds will be enough. But you have places where you have permanent transmission and a lot of contact because of occupations and domestic use of the water by women. In this high transmission area, maybe you will need to treat the same frequency as for school-age children. Yeah. But there are some areas where with 3 rounds, the morbidity can be dramatically reduced. Yeah. So it cannot be a uniform decision. It can be case by case according to the type of transmission and the contacts.
All right, we're out of time. We're already 10 minutes over. We're supposed to be back here at 2:40 to continue on to the next round. We will have more time for comments and questions then, but also you can grab each other outside. So we'll be back in 20 minutes. Victoria, everyone keeps switching up. Victoria Toué, is that how I pronounce it now? Okay. Victoria is the program manager for HKI in Sierra Leone, and she's going to be talking about their experience using the ESPEN community tool for schistosomiasis. Toué, okay.
Well, hello, good afternoon, everyone, and welcome back. Thank you, Darren, for the introduction. I'm Victoria Toué. I'm the NTD Program Manager at Helen Keller International Sierra Leone. And I'll briefly be sharing our experience in using the ESPEN Schistosomiasis Community Tool to facilitate subdistrict MDA. This presentation is made possible by the generous support from the American people. We are grateful for their support. So as a background, Sierra Leone is one of the 24 countries that were trained on the use of the ESPEN community tool about 3 years ago. And this tool is a means to help the program, the national program, review existing data at sub-district level, and also to be able to estimate prevalence for sub-districts that are without data. The worksheets has 3 main areas. We have the introduction, wherein we have the instruction section and the data dictionary worksheets. We also have the inputs worksheets. This includes the demo data, the epidata, that's where we can find prevalence over time, and geodata, including the endemicity and JRSM information. We have the analysis and outputs worksheets. This has two main sheets, the subdistrict analysis and the summary of the subdistrict data, and then the output summary worksheet. This tool can also help to calculate prevalence when there is an existing data. So when we have data within the tool, the ESPEN tool helps to calculate the data using the upper bound diagnosis. As we can see from the charts on my right, this helps to assign endemicity category and also help to decide the next steps for treatment at the subdistrict level. So the prevalence at subdistrict level is calculated using the total positives over the number examined, total examined, times 100 by the diagnostic tool. If we look downward, you will see as an example for Kailaung, the Mandu there is the chiefdom as the ward, and the prevalence for that particular chiefdom was used based on the Keto-Cat method of 28.5%. So if there is no data, existing data, I think some discussions went on earlier on this afternoon. The estimates are based on local knowledge on environmental suitability, as well as looking at similarity with neighboring sub-districts. So we apply, the program applies treatment decisions based on the prevalence at the neighboring sub-district level. We also try to compare, we try to compare, I think there was a question from Rachel earlier on, to compare the two tools, the tracker, the Schistosomiasis tracker, as well as the ESPEN tool. And Hannah had gone into detail with the Schisto tracker. So just to reiterate that the tracker helps to collate historical data, wherein it helps in decision making for treatments. So these data are within over a period of years being tracked with the Schisto disease tracker for decision making. Yes, so comparing these two, we see that, as I mentioned just a while ago, that the tracker helps to track change in the prevalence over time. It enables the identification of hotspots or to identify progress made over the years. Whilst also for the ESPEN tool, we see that the main aspects of the tool is in terms of the drug request for praziquantel, wherein it automatically uses the JRSM to calculate drug requests for both children as well as adults. For the Schisto tracker, we see that the focus is mainly on endemicity, wherein the population projections that is inputted from the ESPEN tool is being used to classify sub-district endemicity. Whereas for the ESPEN tool, projections are made at multi-year level. So we have a projection for multiple year treatment calculations done with the ESPEN tool. One thing to note, however, is that looking at the tool, there are some issues of quality checks, quality control checks, wherein we've been able to see that there are some issues with data, missing data, and the tool needs to be updated regularly to be able to effectively enhance the use and the quality. This is just an example of the impact assessment that was completed in 2022, wherein we can see that Anna mentioned that during her presentation, that we had the Schistosomiasis data review meeting in Sierra Leone, and using the Schisto tracker and the complete list of communities, we are able to identify sub-districts with prevalence above 50% for community-wide MDA, wherein we'll be administering praziquantel to both school-age children and adults. And from the tracker, we've identified 24 of these communities, wherein you can see from the ESPEN community tool, 9 communities. So there are some disparities with the numbers in terms of the treatment frequencies. You can see that for the annual treatments, we have 67 sub-districts that should conduct annual MDA for Schisto in FY24 and 2024. And for the Schisto tracker, we have 49. So those are some of the issues we've identified with both tools. Just to re-emphasize the discrepancies we have been saying, we need to really update the ESPEN tool with the most up-to-date information, the data we have. For example, the assessment that was completed last year has not been updated in the tool, so we have to, that's one step to getting that into the tool. And we can see that the data, for example, for Biriwa Chiefdom in Bombali district, we have no data in the tracker, but for the ESPEN tool, we have, for 2016, we have 9.6%. So this has to be updated in the tracker as well for the just concluded assessments. And we can also see that if you see Mara Chiefdom and Goahu, we have same prevalence for 2016, and there is no updated data for 2022. There are also some spelling issues in terms of the names of those sub-districts or communities with what is in the country admin list that we have. Oh, excuse me. Okay. We try to look at the positive and, the disadvantages and advantages of using the tool. And one key disadvantage we've identified is that in terms of the training, during my opening statement, I said Sierra Leone was part of the training for utilization of the tool. And it can interest you to know that the M&E officer within the Ministry of Health, the NTD program, was trained, though it was a virtual training because at the time there were some issues with traveling restrictions. So, and we think that the partners that are involved in the NTD program within the countries should be part of these trainings. So there is need for, I would say, refresher training and involving implementing partners within the countries. There is also the issue of, despite the tool projects sub-district treatments up to 5 years, but as we have seen, there are some issues with the data, updating the recent data into the tool, as well as there are some missing sub-districts, there are prevalence calculations issues, so we need to have proper checks, quality control checks, whilst using the tool. There is a disconnect between policymakers and the donors, as well as the pharmaceutical companies. The tool generates the drug request, but most of the time, for example, it generates the request for adults for communities above 10% prevalence, but the drugs to cater for those adults in those communities are usually not being able to be provided by the donors. It's quite a friendly, user-friendly interface tool, and it's easy to navigate and understand. However, as I said, it needs constant updates of data, recent data. So in conclusion, and for the future, for ESPEN community tool in Sierra Leone, we want to emphasize that it's a valuable tool for decision making at sub-district level for the national program. And it's also, Anna mentioned, it complements the ActWest tracker for sub-district planning. We need to align these different tools, the ESPEN tool, the tracker, and the GSRM, particularly for the drug request. These tools need to be aligned to be able to make the best out of them, to be able to get the best outcome. And also mentioned earlier that there is need to be able to support the drug supply for adults, because the tool helps with the calculation to ensure that the required drug needs are being captured in the tool, but the drugs need to be provided to be able to address and tackle adults that are living in those at-risk communities. I think that's one thing. So one thing we can go with now here is that we need to revitalize the use and the collaboration between and aligning these tools, the ESPEN community tool, the tracker, and the GSRM form, to be able to make the best out of it for the future of ESPEN community tool in Sierra Leone. I thank you all for your attention.
So next we have Dr. Fiona Fleming, who is the Research and Innovation Director at Unlimit Health, formerly SCI, the agency formerly known as SCI.
Thank you. Thanks for the introduction. I'm going to provide some insights from the Schistosomiasis Oversampling Study, which I'll refer to as SOS, thank you, in terms of facilitating subdistrict mass drug administration. And the subtitle is From SOS to SPA. And I'll reveal what SPA is later. It's not about going and getting some massages and going into warm pools. It's a bit harder work than that, but hopefully simplified. And I'm presenting on behalf of what we've been calling ourselves the SOS Secretariat, or Hot Sauce, as we've also been called, which is myself, Penelope Vanatsu, Katie Gass, Rachel Pullen, and Stella Kefa. And we have Rachel and Stella in the room with us this afternoon. So first of all, a bit of context setting for SOS, just providing an overview of the Schistosomiasis Oversampling Study. So in a context where there's a shift from moving from district to sub-district implementation to really take into account the focality of schistosomiasis infection, and knowing that there are different, as we've even heard today, there are different survey designs used by different countries and at different time points, how could we start standardizing this approach to impact assessments a bit better? And until geostatistical tools and systems are ready for ministries of health to use, which is in the works, and until there are better diagnostics and there are systems in place to do community by community identification of prevalence, what is this impact assessment that ministries of health would be able to use? And so the goal of SOS was to identify an optimal survey sampling method for conducting impact assessments, which was feasible for country programs, cost-effective and resulted in appropriate treatment classification, so minimizing over and under treatment. By impact assessment, I don't think I need to go into this too much because I think we've heard today, but essentially it's a tool, it's a survey to be able to change or hopefully change your decision on preventive chemotherapy. Or do you stay the same, do you increase treatment, or do you reduce treatment? And really should be taken at least after 5 rounds of mass drug administration where there has been at least 75% treatment coverage. And we're really looking to classify a survey area, and I'll go into that in more detail, a district or subdistrict, as either above or below this 10% threshold, which again has already been mentioned, but comes from the WHO guidelines, which were released last year, which say that if you're 10% prevalence or above, that the strategy is annual treatment to the whole community above 2 years of age. And if you're below 10% prevalence, if there has been a program of regular preventive chemotherapy, then you would maintain or reduce your current strategy. But if there's been no regular preventive chemotherapy, then you would use a clinical test and treat approach. And I'm not going into the details and the discussion around each of these decisions, but this is just to highlight that the 10% threshold is a really important one for ministries of health to support their decision making. SOS was conducted in Ghana, Togo, Mali, and Côte d'Ivoire, and very pleased that 3 of the countries are in the room right now. So if there's any specific questions, they can go to the Ministry of Health teams and principal investigators. In each of the countries, and these represented different archetypes, we sampled in 3 contiguous districts in 40 to 50% of all communities within those districts, hence this term oversampling. We sampled far more communities than one would ever really want to sample in a standardized programmatic survey. And we collected a comprehensive parasitological data from school-aged children, and in a subset of sites, we collected adult data. We were also very fortunate in that 3 additional ministries of health who had collected similar but different but very dense survey data, Kenya, Ethiopia, and Burundi, all shared their data with us so that we could use it in the analysis phase. And I'm going to really simplify the analysis because I'm not the one who led it. This was led by Penelope Vanatsu's team and Rachel Pullen's teams. And if you want further information on this, please speak to Rachel. And so using the Bayesian geostatistical models, we generated truth prevalence surfaces. And then we used those prevalence surfaces to be able to classify each of the evaluation units in terms of how well they were classifying treatment for above 10% or below 10%. We then use these truth surfaces to simulate different survey designs, and some of those survey designs had been identified back in 2018 by a WHO working group. And then again, we evaluated how well these survey designs correctly classified the evaluation unit in terms of under and over treatment. And just a graphic representation of each of the source country data. So the graphs on the left indicate the 3 contiguous districts, and each of the dots is a site that was sampled. So you can see many sites were sampled, where green is 0 prevalence and dark red is above 50%. And on the right, the graph on the right for each country is then the truth surface that's been created from those data and the other covariates that were used in the models. And you can see for each of these countries where there's been 5 or more rounds, in some countries even 10 rounds of treatment, the prevalence of schistosomiasis is varied within these areas, but also very varied between the countries. So using these data, and we actually had a session at the virtual COR-NTD session last year called Finding Goldilocks, where we were trying to discuss with the participants what would be the appropriate implementation unit and evaluation units for these surveys. And so based on those discussions, based on discussions with our technical advisory group, And then also crucially, the Ministry of Health, principal investigators of SOS, as well as some other Ministry of Health teams, and from the African region, some schisto experts. We sort of continued the discussions about what appropriate valuation unit would be, and we shared the data and some of the evidence and some of the decisions that we were trying to make. And so I'm now going to sort of highlight what those decisions were. So when the implementation unit for schistosomiasis is a subdistrict, what's the appropriate evaluation unit for conducting impact assessments? And just to reiterate, an evaluation unit is the geographic area for which an impact assessment is conducted. So you might have a district as an evaluation unit, but you'd still be making decisions on implementation at a sub-district. So if we take these data here, again, we're really wanting to look at this 10% threshold. So are most of the sites above 10% prevalence, or are they in this pink and red color? Or are most sites below 10% prevalence, or are they in the blue and the yellow? Well, in this example, we can see that prevalence differs between the villages. There is variation, but the majority of sites are over 10% prevalence. So there's a lot more homogeneity than we sort of anticipated. And then in a different location, you can see here that, again, there's prevalence in many sites. It's above 10% prevalence, so these three colors, pinky, reddy colors. But in the rest of the districts, there's a lot more prevalence that's below 10%. So it's more homogeneous in the blue, yellow areas, and a bit more heterogeneity in the middle of these three contiguous districts. So how can we use that data? So where the IUs, where there's prevalence consistently low or consistently high, conducting impact assessments in each of those sub-districts would be a bit overkill. It would be inefficient because ultimately all the sub-districts would end up with the same treatment decision. So you can see here within these districts, so these are actually sub-district boundaries in black, but you can see that each of them would end up either homogeneously high on the left, where the treatment decision in each of those would be annual treatment, or on the right, homogeneously low, where they're all below 10%, and so the same sub-district decision, there would be reduced treatment. So in such settings, would it be more efficient of us to use resources if we were to conduct a district-level impact assessment survey? So here, we've got the district-level boundaries in black instead of the sub-district. However, there's still stumbling over my words, areas of heterogeneity where you would still need to conduct an impact assessment at the sub-district level. So here you can see there's a bit more variation in prevalence in these areas. So we had, obviously, with the SOS data, we had the advantage of we had the data, so we could see where it was homogeneous or we could see where it was heterogeneous. However, not all countries have those data, and I must say that Togo is, compared to, I think, all other countries I'm aware of in sub-Saharan Africa, has such a wealth of data. So most countries are not in the fortunate position, and they don't have enough data necessarily to make these decisions. So how can we distill what we learned through SOS and support ministries of health to make some of these decisions? We want to be able to discriminate between districts that look like this, where there's not much variation, to districts that look like this, when there's a lot more variation. And we need to think about classifying sub-districts as accurately as possible to minimize under and over treatment and trade that off with reducing the survey effort that ministries of health have to put in, especially where the prevalence might be very similar in an area. So what are the survey designs that allow us to do this, and how do they perform? Well, I'm going to fast forward a little bit and not go into the detail. Again, we would be happy as a team to be able to share more data with you as to the evidence that we shared with the Ministry of Health Programme Managers, with the African regional schistosomiasis experts and the TAGs and other partners at a meeting that we held earlier this year in Kenya, where we came to some of these decisions. We'd be happy to share any of that information, but I'm going to distill it now and move forward and say that what we came out with was the Schistosomiasis Practical and Precision Assessments, which is SPA, so not quite as relaxing as that massage you were thinking about. So what is SPA? Well, it's a two-step strategy, with step one being the practical assessment, which is designed to determine the prevalence of schistosomiasis in a district, how much homogeneity is there, and how you can apply that treatment decision. But it will also help you determine if there's heterogeneity, and therefore if you need to move forward to a precision assessment and do sub-district level impact assessments in each of the units to be able to determine whether you're above or below that 10% threshold and what your treatment decision is. So we've put this into a framework to support decision making. And the number of sites and the number of school-aged children that you'll see within this were decisions that were made by the Africa regional experts and the ministries of health during the meeting in Kenya. So stage one, the practical assessment, is 15 sites and 30 kids within a district, and they're selected using systematic sampling, so that you would have one site or almost one site per sub-district. And with the results of the practical assessment, if you had 0 or 1 sites within those 15 that were above 10% prevalence, then you would determine that you're homogeneously low, and your treatment decision would be to maintain or reduce your treatment strategy, as per the WHO guidelines. And if you had 8 to 15 sites within those 15 that were above 10%, then you would determine that district as being homogeneously high, and you would do annual treatment in each of the sub-districts. Where you had 2 to 7 sites, that would determine that you've got some heterogeneity around that 10% prevalence threshold, and that you would have to move to a precision assessment. Or you might feel that there's sufficient data there from the practical, because if you've got a very small district, and those 15 sites were actually quite a lot of the overall number of sites in that district, you might feel that there's good enough to make a decision. But if it's a very large district and actually 15 sites is a drop in the ocean, then you have this tool then to go ahead and do precision assessment, which would be sampling in 4 sites, 20 school-aged children within each sub-district. And those sites would be selected purposively next to water bodies or known areas of schistosomiasis transmission. In some countries where there's a wealth of data, I'll get to that point. So the results of precision assessment is that if you had a mean prevalence of all those 4 sites in a sub-district that were above 10% prevalence, then your treatment decision would be annual in each of the sub-IUs. And then if it was below 10%, across all sites, then your decision would be that you're below the 10% threshold, and you would maintain or reduce your treatment. In some countries where there's a wealth of data, or there's a lot of other data that support knowing where schistosomiasis is, or there might be just parts of the country where you think that there's a bit more variation around that 10%, then a Ministry of Health might want to go straight to stage 2. But ultimately, stage 1 helps to determine how much homogeneity is there, how much variation is there around that 10%. And if there's not, we can do one district level survey and make those sub-district decisions without having to do a survey in each one. Anyway, moving on to my last slide. How does SPA facilitate sub-district decisions? So we've just been hearing about the ESPEN Community Data Analysis Tool, or the Schistosomiasis Workbook as it's often called, which is a collection of data at the sub-district level for schistosomiasis, which, as has been pointed out by Victoria, doesn't contain necessarily all the historical information, but contains data from about 2015 onwards about number of treatment rounds, about prevalence from different surveys, and ultimately is used to determine how much praziquantel is required for a country. We envisage then, and have had some great conversations with WHO and ESPEN, that then Ministries of Health can then use the ESPEN workbook to determine, as they would also the tracker, to determine, well, where do we need to do these surveys? And then that's where the SPA would fit in. You would then use the SPA to determine whether you're doing your practical, your precision, or maybe your practical, then your precision. You could also use the WHO Schistosomiasis transmission risk assessment that's been developed in some of those sites. And ultimately, those data would then feed back into ESPEN through the EpiRef forms, and the data would be then used to update the ESPEN workbooks for more accurate praziquantal forecasts. We know that the SPA is also going to be incorporated into the M&E framework for schistosomiasis and STH that's being developed by a WHO working group. And ultimately, you know, SPA, with these different tools, what we've been hearing about today will ultimately lead to more efficient use of praziquantal, reduce under and over treatment, getting treatment to individuals who need it and not treating those individuals who don't need treatment, and will help to achieve the WHO target of elimination as a public health problem by 2030. So just some thank yous for the 4 SOS Ministries of Health that led the studies, the SOS Secretariat partners, and the donors USAID, Bill and Melinda Gates Foundation through COR-NTD. Thank you very much for listening.
We got a little bit of time. We do have a couple of online surveys that we're going to try and get to, but we can do a little bit of Q&A for Fiona and Victoria. Amadou, do you want to make a comment on sort of progress, or do you want to wait until after the Q&A session? I know this is a lot of this is stemming from WHO policy decisions and countries that have been working. Okay, so why don't you come on up? In case, I'm pretty sure everybody knows Dr. Amadou Garba, the schistofocal point at WHO. Sorry.
Thank you, Darren. So I would like to comment on the session in general. The title of the session is Management, Monitoring and Tracking of Subdistrict Implementation of Schistosomiasis. So, WHO has recommended long time implementation of schistosomiasis at community level. The previous recommendations and the current recommendations are for implementation of schistosomiasis at community level, because the disease is focal and it is important to target the people that need the intervention. So seeing now that the schisto community is coming back to the really what is required in order to make progress, I think it's very encouraging, because subdistrict is not the final guidance, but it's a kind of interim before being able to reach or to apply the recommendation of WHO as commanded by the guidelines. Because schisto is focal and M&E is important for schisto interventions to show the achievement of the targets. The new NTD roadmap have set the elimination of schistosomiasis as public health problem as a target. And we need also to monitor in order to really see the changes and to adjust the interventions to the impact produced by the interventions. We know that schisto is prevalent in tropical and subtropical areas. And maybe for people who don't know, because we need some conditions in order to have schistosomiasis. And the first condition is to have water, fresh water body. And I think this is a criteria to exclude areas from treatment and from cell intervention. No water, no schisto. This is important. The second point is you need to have the snails, infected snails, and the third condition is the contact. Contact of people with this contaminated water plant. This makes schisto different from LF or from onco, where you have flies that can go 30 kilometers or mosquitoes. So you cannot just calculate all the people living in the area and assume that they have schisto or they should have schisto. This is among the reasons we continue to advocate for community or village-based intervention. And this third point is related to contact related also to human behavior, because schisto is a disease due to human behavior. You can live in the place, if you don't have any contact, you are not going to be infected, because you need to be in the water plant in order to get the infection. And how people get infected, because of their domestic occupations, for women, for example, and also for men taking water, and also the work, because there are farmers, they are doing cultivating rice, etc. And another point is also the influence or the effect of irrigation on transmission, because the irrigation canals are a place where the maximum infection takes place in endemic areas, because the normal transmission water plants, the transmission is not so strong compared to areas where you have canal and where people are in permanence in the water plant. So it's important to have this monitoring and evaluation, but also it is important to think about the requirement for what is needed for treatment. Because of this transmission, which is different, the treatment also of the people living in the area also need to be different. So there are some areas where it is important to also treat adults, but you have also areas where maybe the treatment of adult is not required. The transmission is not uniform. You can have 50% prevalence in school-age children and have a completely different pattern in adults. If it is a permanent transmission, you are going to have a peak in 13 to 14 years old. It will go down, and then you are going to have a kind of plateau because of the adult transmission in adults. And this is different. Why? Because of the changes in the urinary organs for schistosomiasis, and because of immunity. This is the reason why when I hear some people say, no, you don't have eggs in adults, etc., etc. Yes, for hematobium it's possible. Why? Because every time eggs are released, they cross through the bladder wall, and you have blood in the bladder. At the same time, you have also fibrosis, which is created in the bladder. And this fibrosis limits the number of eggs going out. It doesn't mean that you don't have the worms in your bladder vessel. They are there. They produce the eggs, but they are kept in the body. And they are the eggs that are dangerous for human, because they are the one doing the fibrosis, the granuloma, the fibrosis, the calcification, and the severe morbidity. They are not seen outside. So treating adults is something which is important. And countries need to think about, it's recommended by WHO, but look at the situation case by case. The other point with regard to monitoring and evaluation is the number of sites to survey, the workload, etc., etc. Just because people think about one way of doing the survey. A central team in the capital city, the program manager with 3 people, 4 people, how can they survey a whole country? There is a system, a health system is there. I don't know a single district in Africa without a laboratory, without lab technicians, and without microscope. It doesn't exist. Because I used to be a medical doctor in a district 30 years ago, and at that time, in the district, you have a car, you have a laboratory, simple, with microscope, and you have lab technicians. So what is missing? The missing is first to think that Schisto should be integrated to the health system. This is the key. Without integration, you are not going to be able to do the post-elimination surveillance, because I don't see how you can monitor if an area where you achieve a very low prevalence, how you can monitor the change over time, because it's something which is extremely fragile. You do the survey this year, you come 2 years after, the prevalence would have changed. So in this kind of condition, without a close monitoring, how can we eliminate or declare the area having eliminated the disease as public health problem and just leave? So there is a need for integration of the surveys and all the Schisto activities into the health system. And this morning, the director of NTD, in his speech, repeated several times this need of integration, because this is the way to sustain the achievement, moving towards the eliminate the transmission interruption. You train the district, they will do their own survey, they will monitor their area, and they will decide on the need of retreating in order to maintain the low prevalence achieved, or just continue monitoring. And even in hematobiome endemic countries, you can do the mapping using, or the impact assessment using dipstick. It's possible to do a survey during MDA. It's very easy. You buy your dipstick, you do the training. During the training for medicine distribution, you train the CDDs. They will go to the school, they will sample the urine with hemastix, and they will bring you the result of each village. Where is the high cost? Because people try to compare Schisto to other diseases, but the money which is spent for LF to do pre-TAS, TAS 1, TAS 2, TAS 3, etc., and each of them costing between $5,000 and $10,000 US per district, with, I would say, 20% or 10% of this money, we can complete the impact assessment or the remapping of schistosomiasis and provide the treatment to the people in need and exclude people that do not need treatment. Because this morning there is an area with 0%, but it could be non-endemic, for example. And this is important because, and the decision proposed was to continue doing MDA. And this is not ethical because the situation can be refined just by doing a simple survey in the villages and confirm that the prevalence is 0, and then even the health worker of the sub-district can monitor the situation in this area. So these are, I think, some thoughts with regard to the impact assessment and evaluation for Schisto. I don't think it's expensive. We need to really think about the health system, train people to monitor their own area. This is the only way to maintain the achievement and to progress towards the elimination of the disease. The second point is also about integration. It's about conducting a coordinated MDA. As I said, this is what is recommended by WHO since the beginning of NTD programs. Countries are asked to do comorbidity or co-prevalence maps. And then, according to the overlap of the disease, decide about package of intervention. So if you have STH, Schisto, LF, Onco, these are the medicine to be distributed in the area. It is the same people. You can do the training for them at the same time, and they can distribute the medicine at the same period. We don't have enough information about the safety of co-administration of the medicine, but WHO recommend a sequential administration, starting with the MDA with albendazole, ivermectin, if you have Onco, LF, and STH, followed by azithromycin for trachoma, and ending with praziquantel, for example. You can treat the community in a period of a month, and you can collect your data and apply for your medicine. This is something which is cost-effective, and I think it's important to think about this integration or this co-administration of PCNTD medicine. So I think I have only 1 minute left.
That was 2 minutes ago.
Okay, so last I would like to congratulate the presenters for the work done. It's really very impressive. And during the GSA, I think, meeting, WHO will present more about the workbook and the work that we are currently doing to improve this tool. Thank you.
All right, thank you, Dr. Garba. There's a lot packed into that. But we can go ahead and move to some Q&A. Do we want to try and get the survey up on the board while we do this? After the Q&A. Okay. Are there any questions or answers for all these people? Where's the microphone? Either I saw your hand.
Yes, thank you, Darren.
Fiona and Victoria.
So, Maurice Odire from Cambridge. Mine is just to check whether there's efforts to ensure that the current JRSM is aligned to allow the subdistricting or community requisitions for medicines, because I think that's one of the challenges we've had a lot from the program managers, that they are not able to input data that's at lower administrative units below the district. Thank you.
I can't answer specifically, but I do think, well, before Amadou says anything, I do know that ESPEN and WHO held workshops, a Francophone and an Anglophone one in, I think they were in March, maybe this year, where they brought countries to Brazzaville to specifically work out and correct all that sub-district level information, populations, etc. But I'll let Amadou add on. I think there's a significant investment to make them better.
Yes, the Schisto workbook will be included in the JAP, and it will be the form which is going to be used to populate the JAP. So all the sub-district data will be combined in district-level data. So the sub-district form will be as a second page of the Schisto JAP form.
So they're going to fill out 2 forms?
Yeah, 2 forms.
Yeah, I'm intrigued and by many things, but one is Amadou gave a passionate argument for why you would expect Schisto only to be found in very particular circumstances, which would imply a high degree of focality. And so I'm sure the SOS team must have had discussions about how to reconcile that with the apparently very broadly based, relatively uniform prevalence of Schisto across wide areas of the countries that of some of the countries that you looked at.
I mean, we definitely saw so for Ghana, for example, around Lake Volta, it was very clear where there was a large water body. There was such a strong relationship then with proximity to that lake and presence of schistosomiasis, with it being higher on the lakeshore. But I would say in the other countries where the water bodies were more dispersed, it was much harder to predict exactly what the prevalence of schistosomiasis would be. I'll ask Rachel to give a bit more of a in-depth explanation of what I've just said. I mean, I feel like I've oversimplified it.
I think the key thing with...
Microphone.
Oh, sorry. The key thing with some of that analysis is that we were looking at above and below 10%. So there may still be a lot of heterogeneity and focality, but not around that crucial decision threshold. And so I think when we look at it, specifically thinking about the decision threshold, some of that focality and the heterogeneity gets hidden because... So I don't know if that's addressed. I missed the first half of your question.
Well, in this one country, there were huge areas which were uniformly predicted to be over 10%. And that's what I find difficult as an empiricist.
In Mali... Yeah, in Mali it was really high everywhere.
Because they say that the mechanistic arguments sound compelling, and yet you have very extensive geographical areas where there was 10% or more of prevalence, but it's almost uniformly across a substantial fraction of these numbers. I mean, is it the presence of very small water bodies?
Yeah, and it's very seasonal, and lots of flooding, so lots of water bodies there. Yeah.
So the question then is, I mean, when you say close to a water body, what was close?
Everywhere's close.
Yeah. And might I put Steffi on the spot a little bit and say that in Zanzibar it's a similar situation, that proximity to water body when there's so many small water bodies. I don't know if you want to...
We have done this analysis in Zanzibar, like with really sampling a lot of households in different distances to water bodies, and it was quite clear that it was really the households within a 1 kilometer or 1 to 2 kilometer radius had like an 18 times higher risk than those away or further away than 2 kilometers. And similarly, schools that were within a 1 kilometer radius of a water body.
I mean, I think it's going to your earlier point on focality, and what does that mean? And it's not going to be a village. I mean, maybe that village is something, but it could spread much farther out. Johannes, I think you had your hand.
Thank you. It's Johannes Waltz from Merck. Just a very short list of questions and a very quick comments. As I was listening to the presentations, which are great, and we many of us know what is happening, but I was listening with some hope and largely desperation. Real desperation about the amounts of drugs which we continue to waste each and every year. This is just unacceptable. I know Rome wasn't built in a day, but we can't continue like that. This is now the case for 5 to 10 countries, if we're lucky. We deliver every year to 45 countries. You can imagine the amounts of drugs we waste each and every year. It's totally unacceptable. And just very quickly, for better or worse, the adult treatment under the new treatment guidelines. We have opened Pandora's box with that, and Victoria, you mentioned it, the ESPEN tool is out there. It generates the figures. But the figures are unreal, and they are of no meaning, because we have cumulatively, up to now, for 24, demand for 160 million tablets additionally of praziquantel. I don't see what the point is, because nobody will be able to service that, nor should we, because it's not necessary. And that brings me back to my sort of slight hope that we can move in a new environment. Thanks.
I think that's a very important point. There is a somewhat strong disconnect between policy, implementation, and support that isn't being addressed. Yes.
May I be sneaky and just add one response to Johannes as well and say, yes, this is only for SOS anyway, it's only 4 or 5 countries now, but now with SPA, that will then be a tool for all countries to be able to have better data, to have better praziquantal estimates, and so you can't build Rome in a day.
Okay, thank you very much. I'm Anthony Betty from Liberia. My question goes to Cathy concerning the SPA. We did an impact survey before, and then we have a various sentinel site. If in Liberia I want to do a practical or precision assessment, do I have the right to choose those same sentinel site in my previous impact assessment for the practical assessment?
Anthony. So your question is, if you've previously had sentinel sites, could you include those sentinel sites within your site selection for the practical or the precision assessments? And I would say that for practical assessment, I think depending on how those sentinel sites are distributed within the district or county, that they could be considered. I'm not sure how useful the data will be in terms of comparing over time if you wanted to compare the old data to the new data, but I think those historical sites could be considered depending on their distribution for practical and similar for precision. Thank you for the question. And I must also say as well, there are some countries that are piloting the SPA approach, and Liberia is going to be one of them, and Ghana have already piloted. They're the first pilot country. And Kenya just held a multi-day workshop where they went through 32 counties and made decisions about whether they were going to go for practical or precision assessments, which was a big data deep dive, is similar to what Anna was mentioning earlier.
Hi there. It's Mike French from RTI International. A very quick comment and then a question. I've heard Johannes use the Rome wasn't built in a day line for at least 5 years. And it probably took longer than that to build Rome, but you know, we should check how long it took. My question is, for the Fiona, for the SOS reanalysis, were you able to identify how many districts, EUs, IUs would have changed implementation approach under the new approach you were using? Because the very valid criticism we've had from funders in the past is, what's the point in doing this if the treatment approach is not going to change? So I wondered if that came out.
We haven't looked at that under this particular project, but similar actually to what Anna was presenting earlier, but this is more with geostatistical mapping under the Deworming and Innovation Fund with End Fund. We've looked at that and sort of shown the efficiency gains in terms of survey and MDA, which shows that actually doing sub-district level decision making does increase efficiency. But we've had the same questions.
Two more, and then we'll be done.
I'm very sorry if this was covered, so I got caught up in the hallway. But just to build off Mike's question, I was wondering, after this study, how has the demand for medicines changed? Because is it believed that when you go to the sub-district, that it still averages out to be a similar overall level of demand, or are you seeing that there's an increase or decrease? Because it could go either way. I was just wondering what you guys have initially seen.
So because SOS is more about the survey design and finding the best survey design, we haven't looked at that. Well, if a Ministry of Health then implements it, how does that change its decision? Although that would be a lovely next step that we could. But Anna did present data earlier on to what that what decisions might change, how praziquantal needs might change. Remind me, Juliet, what was your point again? Sorry.
My point was that, so we've been showing how like kind of different districts would change over and what the proportion is. I'm just wondering how it balances out overall and whether we end up needing more praziquantal or less.
Rachel would like to respond.
I think there was about a 40% reduction in Anna's slide there.
We did look at that a bit when we were looking at this, what is the optimal IU size or evaluation size, and compared that with IU sizes. And so we looked at it with these risk surfaces and then those other countries as well, and Ethiopia. And what we generally see is you do see improvements in under and over treatment, in reducing the amount of under and over treatment as your implementation units get smaller, and it kind of levels off. So there's a certain thing at which getting smaller doesn't give incremental gains anymore, and at the same time as they get bigger. But there is a key difference between like the average district size and the average subdistrict size in terms of not just the numbers, but the actual amount of under and over treatment reduces substantially as you get to smaller implementation units. So it doesn't really average out. Even if the total drug request might remain similar, you've got more appropriate allocation of that drug request. Yeah.
Yeah.
Yeah, mine is very short. If you are a beginner, that is if you've been treating at the district level and now you want to move to the sub-district level as being demanded by WHO, which of the tools would you use in terms of the tracker? Should you use the ESPEN one or what was presented? What should you do?
You should use the tracker. Everybody else can use it.
Yes, so Anna will help in help me in answering this, but I will recommend the tracker for the beginners, and then move on to populating the ESPEN tool. Anna?
Yeah. So, I mean, we use the ESPEN tool to start the tracker for all the countries that we started. So it's not like the ESPEN tool has been redundant. We use that as a basis. I would say that the tracker is kind of ESPEN tool version 2.0. It's like the upgraded version where the data's newer, it's been better QC'd. The sub-district lists have been verified with the country. It's not just one person, one M&E officer from the NTDP that has done this. I mean, we did it with you with the tracker and the deep dive. We do it with the entire NTDP team, with multiple people, with multiple M&E officers from both the government and FHI. So I would be using the tracker, but the next steps really are to update the ESPEN community tool with newer data and just QC the ESPEN community tool. So that's what we'd like to do next, is triangulate so that the drug requests are more accurate.
I think I'd also say that there are fewer assumptions in the tracker than there are in the ESPEN tool. Did you want to add to that?
Yes. It's a comment because I think for program manager, we have a challenge with the number of tools. We have many tools and sometimes it's very difficult for us to be ready to have in our team somebody who could do all this job. So this is comment, and also it's like you asked to see how all these tools can work together, or all these providers can work together to, for example, if it's possible to have a link between these tools. If I provide data for this tool, can I have it directly to another tool? It will help us. It's not only for schistosomiasis, but also for onco we have onco tracker, we have SOC. Is a comment just to see if it's possible. Thank you.
And I am a little worried that we're not going to have any outputs from this. 1, 2.
Okay. No, I was just going to make a quick comment or question. So has the group that's been developing and implementing the tracker, because certainly for USAID funded countries, this is great that you've got a complementary tool, but for non-USAID funded countries that are reliant on the ESPEN tool, I would say rather than obviate ESPEN, can we please make the ESPEN tools better from all of the learning that you've had so that the world can turn to one tool, and where USAID is able to support the level of technical assistance that the programs have received, that's awesome. But to make sure that the ESPEN collection tools and analytics are there for everyone. So if there's anything we could do from the foundation side to make that happen for the next, we'd love to do that, because I think we want every bit that you've learned to also translate it into an improved ESPEN system.
I think to what Anna was saying earlier, it's the LOE is the big challenge there.
I have one question for Anna. ESPEN tool use the Schistosomiasis risk assessment tool. And when you, during the presentation, we see that the tool which was presented by our colleague from Sierra Leone, when the site don't have data, the prevalence is considered as a no. I think it's very important for the future to consider the Schistosomiasis risk assessment tool, because this tool can allow to capture information from local environment, also the community knowledge. This kind of data can be used also to classify endemic, classify a site prevalence. Why you don't use it, the risk assessment tool developed by ESPEN?
So I would like to comment on the ESPEN workbook, community workbooks. So WHO has started updating these Schisto workbooks with all the data that have been provided to WHO. This tool is much more comprehensive than the tracker, because you have the prevalence data per subdistrict and per site. You have also estimates of medicine needs per age category for preschool-age children, for school-age children, for adults, according to the subdistrict prevalence. You have also estimate of remapping need in case there is no point prevalence for a subdistrict. You have also estimate forecast of medicine based on the prevalence and the number of rounds of treatment already provided to the area and the impact of these MDAs. So these forms have been updated. They will be shared with country programs. And I will request you, please, to look at your own data. Because the thing which is missing is that when the form is provided by ESPEN, they just consider that it's what it should be. You see, they don't look at it. They need to go back to their own forms and check. Because some sub-districts have received treatment without any data. They will need to check if really there is any suitability for the transmission so that they can maintain the treatment in those areas. If they think there is no transmission, they can just accept that no treatment is going to be provided to this sub-district because there is no suitability for schistosomiasis transmission. Some areas there are going to, maybe there is no data, but these areas have similar transmission because all are located near a big water body as a contiguous sub-district, and then they will have to maintain the prevalence. So I think these forms are going to be shared with you, program managers. Please look at them and provide any data that have not been integrated into the tool.
All right, I'm going to call it there. We got 5 minutes left. Apparently WHO has sorted everything out already, so we're going to be all good. There is 2 online questionnaires that I think are going to be displayed. Thank you, guys. All right, thank you. I want to, before we finish, I want to thank Anna, Fiona, Victoria, and Dr. Naske for the presentations. Amadou, thank you for your comments. I want to thank all of you for your questions and answers. I think what we saw was that there are a lot of complexities that were not anticipated in putting out guidance and then operationalizing that, and I think this is a step in the right direction. So hopefully we're going to get some feedback on operational research for the future. Thank you all, and have a good evening.